Everybody, welcome back. Another episode of Good Reads. In this episode, I have a 58-year-old male with chest pain and diaphoresis. When we look at the 12 lead, I think we can all agree that there's pretty obvious ST segment elevations there in the inferior leads, 2, 3, and ABF. This is a pretty obvious inferior STEMI. But what I want to caution you about is just hyper-focusing on that ST segment elevation, and you can miss some of the other important things going on here. And so with every 12 lead, I like to start with a systematic approach. I will start with the rate, fast or slow, regular or irregular, and then I look at the rhythm. So when I interpret the rhythm, I can identify if the P waves are originating from the SA node if I have upright P waves in 1, 2, and 3 and a negative deflecting P wave in AVR. If those rules are satisfied, then I know those P waves are originating from the SA node. Now, one thing that did concern me, and if we zoom in a little bit more on the 12 lead, was that I had identified 2 P waves between these QRS complexes. When that happens, that tells me that there are too many P waves for QRS complexes, or I have an AB nodal block. So to identify which one we're dealing with, I like to map out the P waves. Now, the P waves should be regular, right? If they're originating from the SA node like we identified, they should be regular. And so if we draw some, a lot of this in the formatting system that I have will tell me exactly the distance that everything is away. So if we march this out, using the formatting here, there's another P wave, and we can kind of see it kind of buried a little bit in there, about in there, right before the QRS complex. There's a little blip. You can assume that's a P wave. We know this is obviously a P wave out here. There's another P wave, this little blip in the T wave. That's a P wave. And then we have another one here. And if we map this out perfectly, these distances are equal to one another. And so with varying QRS complexes, let me take some of this away. So with varying PR intervals is what I meant to say. Varying PR intervals, we have complete AV dissociation, or otherwise known as a complete heart block in this situation. So this is a complete heart block with an inferior STEMI. And if we were to actually write out the true formal definition and full interpretation of this 12 lead, this would actually be a sinus rhythm, because we have the P waves originating from the SA node with a complete heart block with an inferior STEMI. And the last thing that I want to add onto this is that if we have in the presence of a complete heart block, we need to identify where the escape rhythm is coming from. So what I mean by that is that when we take our heart, the AV node has been taken out of the question, right? Because we now have complete dissociation between the atria up top and the ventricles at the bottom. So when this situation happens in a complete heart block, what ends up occurring is we can either have one of two fail-safe systems, where we have either a fail-safe coming in through the AV bundle itself, and that's known as a junctional escape rhythm, and those rates typically are between 40 and 60. Or we can have a ventricular escape rhythm, and those are usually between 20 and 40 beats per minute. And one thing that kind of differentiates one versus the other is that in the junctional escape rhythm, they're usually narrow QRS complexes, and in the ventricular escape rhythm, they're normally wide QRS complexes. So going back to our 12 lead, if we look, we've identified that yes, it is a sinus rhythm. There is a complete heart block. There is a sinus or an inferior STEMI. And then on top of that, if we look at the rate, we can assume a 6-second strip from a 12 lead. We see 6 overall complexes, roughly giving us a rate somewhere between 50 and 60. That there falls between the junctional escape rhythm. We have narrow QRS complexes. So the total interpretation for this is going to be a sinus rhythm with a complete heart block, junctional escape rhythm, and an inferior STEMI.